Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Good evening, everyone. I'm Rahul Gosain. As always, I'm here with my brother, Rohit Gosain, and we are the Oncology Brothers. But we are two practicing community oncologists. Over the last 3 years, we've used our platform to bridge the gap between academic research and community practice. But the field's moving too fast. Let's make sure we're doing the best for all our patients close to home. Today, most of our patients get treated in these community settings.
Good evening, everyone. I'm Rohit Gosain, other half of Oncology Brothers. Welcome, everyone, and welcome to the virtual audience who's joining us. Today, the topic at hand is latest advances in tumor-agnostic strategies in NTRK fusion-positive cancer. So we have about 90 minutes of the program planned for you. We are joined by world-renowned faculty here, Dr. David Hong from MD Anderson Cancer Center, Dr. Jarushka Naidu from Ireland Cancer Center, Dr. Theodore Latch from Children's Hospital of Philadelphia.
So over the next 90 minutes, we'll start off with Dr. Hong walking us through where are we today in NTRK. You know, we're finding more and more of these mutations because we're looking for it, so the incidence and prevalence is increasing. Then we'll pass it off to Dr. Naidu to touch on NTRK and lung cancer, switching gears with Dr. Latch, focusing on pediatric management when it comes to NTRK, and then this is going to be fun. We'll also take some rapid-fire questions. So to get us started, we'll have Dr. Hong take the stage and start where we are today in NTRK fusion-positive cancer.
All right, thank you guys. So to start off this scan, this was one of our patients in the phase 1 trial. She was a 42-year-old female, mother of 3, with undifferentiated sarcoma. She had progressed through pretty much all lines of therapy for sarcoma, and she was identified to have, through NGS, an ETV6 translocation of NTRK3. She started on a TRK inhibitor, larotrectinib, and as you can see, over a cycle of within several cycles, she went into a near complete response. And she remained in this near complete response for almost 4 years. So, as in lots of historical things in oncology, it took us almost 40 years to get to this point. NTRK was identified in the 80s as an oncogenic driver, and it wasn't until around 2017 when we had the first drugs approved in NTRK fusion. So NTRK biology is a very interesting biology. Really, there are 3 receptors, TRK-A, B, and C, and normally they're involved in neural functions, pain signaling, thermal regulation, regulation of movement, proprioception, actually appetite and body weight. And it's when these fusion proteins occur that leads to this abnormality in tumors. Now, the importance of these different areas and functions is that inhibiting the actual receptor can have effects on some of these neural functions. So we'll talk a little bit about that and the side effects of these drugs. So what happens? Well, we now know that there are multiple gene fusion partners that occur with one of the NTRK genes, TRK1, 2, or 3. We probably don't, I always, once in a while look into the literature and see if they identified a new one. Probably the most common is the ETV6 translocation, but there are many different translocations. And it's relevant partly because DNA-based NGS can pick up some of these, but really many of these will be missed unless you get an RNA-based NGS. So what happens? What happens is that the NTRK gene partner fuses with one of the on the 3' TRK kinase domain, And this leads to a constitutive activation of this pathway leading to tumor growth. Again, there are a number of these as I listed here, and this list continues to grow. So where are these patients found? Probably the best way to differentiate these tumor types is both in adult and then in pediatrics. And within adult, probably rare tumor types and common tumor types. I mean, Ted can comment on this, but pretty much all pediatric cancers are relatively rare, right? But in the common tumor types, such as lung and colorectal, et cetera, the actual prevalence is probably less than 1% to 2%. In more rare tumor types, such as mammary analog secretory carcinoma, I had not even learned about that in oncology in my medical fellowship until I actually started running these trials. It's a subset of salivary gland tumors that almost pathognomonically express NTRK fusion. This secretory histology, whether it's in breast, whether it's in salivary gland tumors, seems to lead to an NTRK fusion. As Ted will probably talk about, in pediatric cancers, there are other prevalences, almost pathognomonic, such as IFS, congenital nephromas, also secretory breast cancer that can occur in children. Probably the most common tumor types, or what we call more common, such as probably thyroid cancer. Thyroid cancer, particularly papillary, they can have up to 5 to 25% expression with NTRK fusion. There are a lot of different algorithms now. ESMO has an algorithm because as to how testing should be done. I think the key here, and if there's one thing I want you to get out of my talk, is that you should test. You should try to find these patients. Because if you are able to find these patients, now that NGS is reimbursed, if you're able to find these patients, it is literally a lottery ticket for some of these metastatic patients. And this, again, is the algorithm, the European algorithm, and for this. Pan-TRK IHC can be of some value. There is a lot of false positives with that, but really the gold standard here is RNA-based NGS. So why am I so excited and why do we care about this? You can see that this was from the initial phase 1 trial application, NDA application of the tumor-agnostic. It was really one of the first approvals in tumor-agnostic therapy. And you can see here, regardless of tumor type, regardless of responsive NTRK gene, fusion partner, et cetera, or age, you're seeing these incredible responses across these patients. And it remains one of the safest drugs. I do a lot of phase 1 trials, So my primary job is to find toxicities in drugs. And the vast majority of these patients get grade 1 or 2 toxicities. Invariably, most people get a slight dizziness associated with this, which remember one of the NTRK2 is involved in proprioception and movement. And so it's not surprising that these patients get this. There are other adverse events. Probably the most common grade 3 adverse event that we see is AST and ALT. Now, none of these patients went into hepatic failure. Usually what you do is you hold the drug and the dose reduce it, and 9 out of 10 times these patients resolve their AST, ALT. Again, this is a recent update last year where we looked again at now, since the phase 1, up to 240 patients. And again, the response rate is still close to 75%. Many of these patients, close to 25% of the patients, went into complete response. You rarely see that in metastatic cancer patients, right? And yet many of these patients went into complete response. And the duration of response, again, is amazing. I still have a patient on the phase 1 trial who is still with me, almost now close to 11 years on the study. And it's, and albeit he stopped responding, but is still stable. This is the most recent update from that ESMO presentation. You can see here duration of response, median duration of response close to 43 months, median progression of response 30.8, and median overall survival has yet to be reached. Most recently, we published in the first line. One question is Is this relevant? Most of our patients in the trials, in the pooled analysis, were patients who were, second line, third line, or refractory to all known chemotherapies. And one question we had was, what about these patients who never received chemotherapy? Will they have as much benefit? And as you can see here, based upon the response rates, the benefit is incredible to those patients who have not gotten it. And so, one question I often get is, if I find an NTRK fusion patient, a patient who's never gotten chemotherapy, should I give him an NTRK inhibitor? And based upon this data, I would suggest likely yes. And again, the median progression-free survival here is 61 months, median overall survival yet not reached. There are other drugs. Entrectinib was the second NTRK inhibitor that was approved, and you can see here very similar response rates, 61.2%. And again, very similar median progression-free survival overall. So, again, the most common side effects here are listed here. There are GI side effects like diarrhea, et cetera, dizziness. And Ted will probably talk a little bit about one of the effects of entrectinib, which we did not really observe in per se in larotrectinib, is there seems to be some more bone fractures in children associated with entrectinib. So, now the first generation NTRK inhibitors, larotrectinib and entrectinib, have now been approved for a while. What about resistance? Well, early on, we started to understand that just like any other small molecule, there's likely going to be resistance. In fact, up front, we started to biopsy these patients, try to understand the mechanism of resistance. Our colleagues at Sloan Kettering, Dr. Drillin and others were really forthcoming in this. And you can see that there are really two major mechanisms of resistance. One is called solvent front mutations, and the other is gatekeeper mutations. There are other more minor mutations like XGFG, and there are other off-target resistance mechanisms, KRAS, MET, IGFR, but I would say probably close to 80% are either solvent front or gatekeeper mutations. And are there second-generation inhibitors? Yes, there are. In fact, one of them is repotrectinib. And repotrectinib is, as many of you may know, is already approved in ROS, non-small cell lung cancer, and recently got an approval also in NTRK tumors. This is the data from repotrectinib. This was a couple of years ago, I think, was also presented by Dr. Drillin. As you can see, and these are patients who were pre-treated with an NTRK TKI, and you can see, albeit not as high as those who have never been treated, still a robust response of 43.2%. Now, we don't have as much duration data as we have for the first generation inhibitors. When somebody comes to me and has had a patient on larotrectinib or entrectinib for a very long period of time, and they start realizing that these patients are progressing, I will invariably get a call, and I will say the first thing you should do is you should biopsy that progression, and to determine what mechanism of resistance, whether it's solvent front, gatekeeper mutation. Sometimes unusual, you may have something like a MET or even a RAS mutation. We have many trials now, and many of you guys know there are these new RAS inhibitors that are emerging. So I always tell my colleagues or somebody who calls me up, please biopsy that mutation and we'll figure out what next to do. And again, this is an NTRK fusion positive patients, pre-treated. Again, really good respectable response. So to end my point of this, I think of all examples, NTRK is an example that precision medicine can work, right? And that it can not only work for short periods of time, but again, like I said, I've had patients on for very long years with these drugs. And when it comes down to it, it's about identifying these patients. It's all about the biomarker. Probably the gold standard, again, is RNA-based NGS. As you know, we now have multiple mechanisms or precision medicine targeted drugs. At least in the United States, is reimbursable. So please try to identify these patients, because if you do find them, you invariably will likely lead to benefit in these patients. Let's see. Eventually, resistance will ensue, but really the next thing you need to do is biopsy the patient to identify what is the mechanism of biopsy. Now, there will be, is there a third generation NTRK inhibitors? There are possibly third generation NTRK inhibitors, but there's also data that some of my colleagues in the lab have generated that maybe rational combinations would work, particularly with EGFR inhibitors in the context of patients who develop resistance to larotrectinib. Okay, I think before we go on, there is the next is actually a video on the patient's perspective on some of these NTRK inhibitors.
This disease has, obviously changed him in so many ways, which I understand because it's made him angry, and you do question why me, why our family.
Yeah, it's essential to get. We must get information and diagnosis as soon as we can, especially these rare cancers.
Yeah, so we got the biopsy results back and we got a telephone call to go and visit the local cancer hospital with the oncologist. So I went with James and we were told that the diagnosis had come back and he'd got the NTRK fusion. The particular consultant had never dealt with it at all. He said in over 30 years of being at that hospital, he'd never dealt with that particular fusion, and neither had anybody else at the hospital.
Yeah, the fact of trying to find out about rare cancer was really difficult. I did find it's internet-based. Struggled with all that, the terminology. Yeah, extremely difficult. But to be honest, I researched it till I couldn't do any more, and then just let it go and trust the consultant.
So it's got to a point now where the tumour has spread to James's sternum, and he's got quite a big mass on his sternum, which is close to his heart. The medication, just from test results, is showing that the oncologist feels it's no longer effective. However, James feels it does help with his breathing. So he is still taking the medication, but a much smaller dose.
And keep fighting for my family. I know Lisa said there's quality and quantity. I've had that discussion myself. Don't just give up. Well, no, I won't. Because I've got my wife and my boys I'll keep fighting for. That is it. 100%.
A very touching story. And thank you so much, David, for laying this important foundation. I just want to reiterate your point that we can get all excited about these approvals. These are remarkable drugs. But if we don't test our patients for this, we are depriving them of this groundbreaking approach. So thank you for stressing the importance of NGS testing, and also something to take home point is RNA-based NGS, because sometimes we are just tied into the DNA aspects of RNA. Thank you. Now we have Dr. Naidu, who will be walking us through the personalized strategies for NTRK fusion-positive lung cancer.
Hi everyone, and thanks for the opportunity to present today. We're going to focus a little bit more on NTRK, but specifically in the context of lung cancer and what data we know of in this particular tumor type. So based on the initial experience published by Dr. Hong and his colleagues in the Lancet Oncology paper, this was the results of the pooled analysis that assessed all solid tumors. So the original approval was based on these 55 patients in whom there was data on objective response, duration of response, progression-free survival, and this initial experience included both adult patients and patients from the pediatric population. But this formed a larger experience of around 159 patients, of which 12 patients had lung cancer. So we have very specific data on this, and exactly as Dr. Hong said, because some of these cancers are common, even though the alteration is rare, we are able to glean some specific insights from them that can inform us about what the behavior of these tumors are likely to be like across solid tumors. So we see here from the paper that was already referenced that the objective response rate is as high as around 79–80% in this experience, and about 16% of patients had complete disappearance of their tumors, so complete responses. And we see many of these indeed had lung cancer, which is of course something that we're not used to seeing at all in the field of non-small cell lung cancer. So taking a deep dive into this with respect specifically to larotrectinib, what we saw here is in these 12 patients, the majority, 75%, sustained an objective response to treatment, and that the median duration of response was not reached. So really very impressive outcomes here, and not something that we typically see with lung cancer. And again, the overall population, the duration of response was around 44 months. Overall survival similar, and then we saw some data as well with regard to CNS response, and again, very favorable at around 75%. These are the specific data that then came into greater detail in a poster presentation at the European Lung Cancer Conference this year. Moreno and colleagues published in 32 patients, and then specifically 27 patients that were accessible for response outcomes. And what we saw here was an objective response rate of around 66%, and then some specific data again around CNS metastases, 12 patients with CNS metastases with an objective response rate of about 67%. This particular data also allowed us to delve deeply, or a little bit deeper, into when should we be giving these treatments, in the first line setting or beyond. And we see here obviously very small numbers, but it does appear to track that the earlier may be better. Another very important take-home message from this was, should we even start treatment on patients who are of a borderline performance status, so might be very physically unwell? And really this ties very nicely into the paradigm that targeted therapy can work even in patients who are very systemically unwell, and that they can work quite rapidly. And we see that even in patients with an ECOG performance status of 3, they had a response to treatment. So we see here some of these data specifically in the lung cancer population. Median duration of response, 34 months, progression-free survival, 22 months, and again, an impressive median overall survival of 39 months. Some of the safety data, I think, important to take into consideration. So here we see that most of the treatment-related adverse events, thankfully, were low-grade in nature, grade 1 and 2. But of those patients in whom there were high-grade toxicities, these were most commonly abnormalities of liver function tests, as well as some toxicities that we as clinicians, probably with increasing familiarity, are usually able to manage. Myalgia, constipation, so really no game changers or rate limiting toxicities that I would say, looking at some of these. Switching gears now to some of the other options that we may have in terms of choices for TRK inhibition, and specifically the data to inform lung cancer. So this is a paper published subsequently by Bob Doebel and colleagues, again across all solid tumors, pooling the analyses of the Star Trek 1 and 2 trials, great names, and ALCA 372001. And very similarly, around 54 patients in this population, but a larger population in whom safety was able to be accessible. Primary endpoint here, of course, objective response and duration of response. Again, here we see in this population an impressive objective response rate of around, in the region of 60%, and a sizable proportion of these patients having lung cancer. So specifically, 22 of these patients had lung cancer, and there was an objective response rate of 63%. Again, impressive duration of response of around 19.9 months, median progression-free survival of 14.9 months, and overall survival not reached. So very similar, I think, here with entrectinib, similar to larotrectinib. Again, we saw some CNS data coming from a dedicated paper from Dr. Cho and colleagues published in Lung Cancer last year. And again, we saw some complete responses and some impressive responses in the brain, 60% in patients with known brain metastases, and then CNS protection in those patients without brain metastases. And we see this in terms of time to CNS progression in the lower Kaplan-Meier curve. And of course, this really affects the quality of life of our patients with lung cancer. This is something that we always look at in terms of a key secondary endpoint and a secondary outcome that really makes a difference in the lives of these patients. So really impressive results, I think, with both of these agents in this setting. This is some further data from the Dimitri paper looking specifically at the intracranial activity of entrectinib across solid tumors, and specifically in lung cancer. And again, an intracranial objective response rate of 64%. Small numbers, but rare occurrence, and therefore I think the most data that we really have in this space. So how are the toxicities different with entrectinib as opposed to larotrectinib? Again, thankfully, most of the toxicities appear to be low grade. The high-grade toxicities, and we do see this actually with some of the targeted therapies now. We're starting to see it with ALK inhibitors and others, weight gain being something that we need to assess, and leading to treatment discontinuation, reduction, or interruption in some instances. So really important to tell our patients these nuances of toxicities to help to inform what might be appropriate for a particular patient. This is a really interesting paper that was subsequently published trying to understand how we can evaluate which agent we may want to try first and what might make sense in terms of long-term outcomes for patients. So this is called a partitioned survival analysis that was published by Roth and colleagues in the last couple of years, trying to project out the survival benefit from either one of these approaches. And from this, you can see that so far from these really statistical projection data, that larotrectinib may just have the edge in terms of progression-free and overall survival. But of course, many different factors here in terms of CNS response, toxicity profile, as well as this that I think should inform a discussion with patients. And then lastly, second generation TKI here, repotrectinib, now also being explored in NTRK fusion-positive solid tumors and particularly lung cancer. So these are data that were presented in 2023 at ESMO by Ben Solomon and colleagues. And in patients with lung cancer, we can see here that the objective response rate was 62%. Again, an impressive 12-month duration of response, 92% of patients still remaining in response at 1 year, and progression-free survival similarly benefiting in those patients, 64%. We see here that in the pre-treated population, perhaps the response rates are not as impressive. And we can see here really that also the duration of response, if you look at the TKI naive patients, 86% of patients had a 12-month duration of response as opposed to just 39% with the TKI pre-treated. So this, again, might help us to select or help inform our treatment choices from here. This is based on the Trident-1 study, and again, a side effect profile also quite distinct and different, with dizziness being the most common treatment-related adverse event here, and occurring in about 51% of patients, a grade 3 toxicity. So this is a little bit different, perhaps a little bit more toxic in terms of how we manage patients. So altogether, the approved TRK inhibitors in advanced non-small cell lung cancer, obviously larotrectinib came first with full FDA approval both in the adult and the pediatric population, and an example of a tumor-agnostic approval based on the presence of the NTRK fusion. Entrectinib, now we see is also an emerging indication and has conditional approval from the FDA. And now repotrectinib having accelerated FDA approval across solid tumors, including the pediatric population. This is the current NCCN guidelines, which are informing our approach for these patients. And you can see here that if an NTRK fusion is identified, certainly any of these options can be considered as preferred options in the first-line setting. And very importantly, if this is only discovered while a patient is on an alternative systemic therapy, the recommendation is to interrupt that therapy and to start one of these treatments, not something that you commonly see in the NCCN guidelines, and really emphasizing the potential benefit and long-term benefit of some of these treatments. So with that, I'd like to then come on to a case study. This is a patient I did phase 1 developmental therapeutics at Sloan Kettering. This is a patient I saw with Alex Drellin. So a 49-year-old Caucasian male who presented initially with a 6-month history of shortness of breath, ischemic heart disease, no significant family history, and a former smoker. We see here a 4.1 centimeter right upper lobe mass with a 19 millimeter right hilar lymph nodes, multiple bony and liver metastases, and 2 small brain metastases. To add complexity here, we see on the CT-guided lung biopsy that the PD-L1 was high. But then at the same time, we saw an NTRK mutation or an NTRK fusion. So based on this, we did stereotactic radiosurgery to the brain metastases. At this time, the patient was acutely symptomatic at the time with the diagnosis of brain metastases, initially with shortness of breath, but did have headache, and this is why we chose to do the SRS first, but then subsequently treated with larotrectinib. Unfortunately, had an initial response to therapy and subsequently progressed with new liver metastases. So in this instance, what would your subsequent treatment options be? So here, what are our subsequent treatment options? So we see entrectinib. This is certainly where we went with this patient. This is an emerging question in those patients who have an oncogenic driver mutation that is rare, in which we may not necessarily know their response to chemoimmunotherapy. Which might you prefer? And in this instance, I think, the sort of knowledge base is always to prefer the targeted therapy first. And that's certainly where I would have gone with this rather than the other options. But your thoughts on that?
Yeah, I think especially for lung cancer, we're so used to sequencing, right? Coming from that mindset of EGFR, ALK inhibitors, where I've used first, and I do have a good agent with close to 29-30% activity, even if they were pre-exposed to TKIs. I would lean into this unless there's gross progression and they're symptomatic and I'm looking for something else.
And again, we know that what we are doing here is palliative intent.
Yes.
So quality of life has to be kept in mind, where pembrolizumab chemotherapy can be put on back burner and relying on making sure however much we can buy with our targeted agents is the key. And on top of that, especially when they're so well tolerated as we just saw. So definitely relying on the targeted.
I'm assuming, knowing Alex, you guys did repeat NGS on this patient. Yeah.
Yes.
Right.
Dr. Naidu, thank you so much for walking through lung cancer and NTRK fusion positive. Now we have Dr. Latch focusing on pediatric cancer management. Full disclosure, I'm an adult medical oncologist, thankfully, so I'm very eager to learn and see if I can draw any parallels. Dr. Latch, all you.
Thank you again, and thank you all to the audience for your attention. It is kind of unique to have a pediatric oncologist up here with a bunch of other medical oncologists. and I actually think that from a drug development standpoint, the TRK inhibitors have been very interesting because pediatric oncology has really been hand in hand with the medical oncologist as these drugs are developed. And as you saw, the approval of larotrectinib included children from the very beginning, and the approval of entrectinib included children 12 and older from the beginning, and very shortly after that, younger children. So it's been a very big pleasure to be able to be part of the development of these agents. But you saw this slide from Dr. Hong looking at the frequency of NTRK fusions in pediatric cancers. As you know, pediatric cancers are more rare. Brain tumors and gliomas are among the most common pediatric cancers, and they're similar to the lung cancer paradigm, where there are rare NTRK fusions in these more common pediatric cancers. But there are these more rare pediatric cancers, things like infantile fibrosarcoma and congenital nasoplastic nephroma, that nearly universally have NTRK gene fusions. And just like in adult cancer, NTRK fusions are enriched in the youngest patients, even within children. So many of our patients are less than a year old on these when they're treated with these agents. And they, in general, I think, occur a little bit more frequently in pediatric cancer, about 2% or 3% of pediatric cancers versus 1 or less than 1% of adult cancer. So I was going to start with a case study that we'll talk about through my presentation. This is a fairly typical patient that I've treated with an NTRK inhibitor, a 7-month-old who presented with a soft tissue sarcoma. You can see of the arm here. This was diagnosed actually at birth, and that was initially thought to be a hemangioma, but when it continued to grow, it was biopsied and was found to be a hypercellular tumor with monomorphic spindle cells, so not a hemangioma, and was thought not to be resectable at the time without amputation. And so when we see a patient like this, we're faced with the same question that we've talked about. How do we test for various molecular alterations that may be driving in this cancer? And this is from a paper that Dr. Albert and I published back in 2020 or 2019 in JCO, looking at different ways to test based on the prevalence that you expect in the tumor. So for something like this, where we think it's most consistent with an infantile fibrosarcoma, there's a variety of methods that you can test, including directed testing for NTRK fusions by FISH, which can be the quickest test if you need to treat the patient immediately. Sometimes these patients can present in extremis with compression of an airway or major neurologic structure. Versus if you have more time or it's a lower frequency tumor, then I completely agree with the recommendation for RNA-based NGS. And in fact, if your FISH is negative, you should still reflex to RNA-based NGS because FISH can have false negatives and other kinase fusions that also can be very targetable or are found in the same tumor types, sort of like the lung paradigm. So you would want to test for those things like ALK and ROS1 fusions as well. So how do we treat pediatric NTRK fusion-positive tumors? And this is data from larotrectinib in patients with extracranial solid tumors enrolled on the phase 1/2 trial. And what you see is really, again, this remarkable response rate. 86% of the patients had an objective response. And really, not to brag, but even better than the adult response data, right? More than half of these patients had complete responses to this therapy. So really, really remarkable efficacy that we have never truly seen in solid tumors before with a single agent targeted therapy. And we see the same with entrectinib. So this, again, is pediatric patients with entrectinib, both those with extracranial solid tumors and those with primary CNS tumors shown with the star. And again, you see a very robust objective response rate with nearly half of patients having a complete response to therapy. The toxicity of these agents in pediatric patients is similar to what you've heard about in the adult patients, although there are some differences. I don't know that I've actually ever had a patient tell me they were dizzy. Many 6-month-olds can't tell you if they're dizzy, so it's hard to know. But even in the older patients who can express those feelings, we think that's less common in pediatric patients. The things we see more commonly are increases in liver function tests and some neutropenia that, again, typically either resolves without any dose modification or with dose adjustment. And needing to discontinue therapy is very rare due to side effects. The side effects of entrectinib are mostly similar. You already heard about, from Dr. Hong about the fact that we do see fractures with these agents, and in particular with entrectinib. This agent was studied in patients who, many of whom had primary CNS tumors and had been on steroids for a long time, so there were multiple risk factors for developing fracture, but it does seem to be associated with at least entrectinib. I will note for any pediatric oncologists who are listening, this is different than our usual paradigm. These are not profoundly immunosuppressive, so I don't give PJP prophylaxis. I give these children all of their routine immunizations, including live immunizations, because, as you've seen, the duration of response to these agents is very long, and we want these children to live long and healthy lives. So you've heard a little bit about these less well-captured adverse events, but they are real, and I think they're on target from inhibition of the TRK receptor in normal tissues. So withdrawal pain can be a real thing, that when patients stop the agent, they can have myalgias that last for days to a couple of weeks. Young children can be fussy in that time. It can be hard to distinguish, but that's something I warn parents about. And some patients even have that as they're coming due for their dose at the 12-hour mark from these agents. So I warn patients about that as well. And then you can definitely see weight gain. You heard about that before, but this is just a growth chart of one of my patients who was treated with larotrectinib, and you can see that has a nearly vertical growth chart after starting the agent. And so we try to work with these patients on exercise and activity to mitigate this effect. The next question I want to talk about is, should TRK inhibitors be used as first-line treatment in pediatric patients? And you heard that they should in adult patients, and I'm going to give you the same conclusion in pediatric patients. This is a study looking at larotrectinib versus standard of care chemotherapy in patients with infantile fibrosarcoma. This study was using a historical control. These cancers are really too rare to do any randomized trial. But in this trial, in this study, we found that larotrectinib was superior to standard of care chemotherapy, both in terms of the time to needing next systemic therapy, which you see in the Kaplan-Meier chart here, as well as in the time to some events that we consider negative for the patient. So needing radiation therapy in a small child, needing a mutilating surgery, or death were all less common in the larotrectinib arm. So we actually have done a prospective frontline trial of larotrectinib for children through the Children's Oncology Group, the ADVL 1823 study. And here you can again see the waterfall plot of patients in cohort A, who are those with infantile fibrosarcoma, and patients in cohort B, which are those with other NTRK fusion-positive solid tumors. And again, you see a very robust level of activity and prolonged event-free survival and very encouraging overall survival in these patients. So we concluded in this paper that larotrectinib and NTRK inhibitors should be considered a frontline treatment for these patients. One of the things that the medical oncologists probably don't think very much about it, but we think about a lot in pediatric patients is formulation, because if you can imagine a 6-month-old and you give them a 1.86 centimeter capsule, that's not going to work for that patient. And so there are pediatric formulations of both entrectinib and larotrectinib, with entrectinib having capsules that can be administered as a suspension or oral pellets that can be administered, and larotrectinib having a commercial liquid oral solution. At the moment, there's not a commercially available pediatric solution for repotrectinib. So back to our patient. This patient was treated with a TRK inhibitor and had a significant response. You can see 12 cycles of therapy on the right. The patient's arm is slightly rotated because they don't keep their arm in the same position. But you can see there's a significant response to therapy, a partial response by RECIST, but there was this remaining area of signal abnormality on MRI. And so then the question is, how long should we treat this patient, and is local control necessary? So this is something I think we probably think more about in the pediatric space. When you have a 6-month-old with a localized tumor, we don't want to commit that patient to 80 years of TRK inhibitor therapy, and so have done some studies looking at the ability to discontinue these therapies and maintain response. And this is data here from the SCOUT trial looking at time after discontinuation to progression. And so what you can see is that patients who discontinued therapy while in response, a proportion of those patients have recurrence. In this trial, it's between 20 to 40 to 50% depending on the arm. But a proportion of those patients are able to maintain that response when therapy is withdrawn, either with local control surgery or in some cases, the blue-green line here, even without local control therapy. We also evaluated this on ADVL 1823, where patients were prescribed a set duration of therapy. So patients got a year of therapy if they had a complete response, or 2 years of therapy if they had an unresectable tumor that did not respond. And we're also eligible to have local control after 6 months on treatment. And what you can see on the right is the event-free survival after stopping therapy. So the red line is those patients who had local control, showing that the vast majority of those patients have maintained their remission. We think potentially curative surgery enabled by TRK inhibitor therapy that shrunk their tumor, and a proportion of patients, in this case about 40%, who did not have local control, also were able to maintain their remission off treatment. So our patient that we treated here, their family decided to discontinue larotrectinib and watch. And what you can see here is that unfortunately 1 month after stopping treatment, there was progression with increased abnormality on the MRI. And so the question that comes up is, how do you treat this patient then? And there have been some work now looking at what happens if you retreat with another first-generation inhibitor versus with a second-generation inhibitor. So both the SCOUT trial and ADVL 1823 had high response rates in those patients who had progression off therapy when they were retreated, 69% on SCOUT and 83% on 1823. And on both studies, all of these patients remained alive despite this drug holiday. So I use this as a rationale for one of my patients talking about trying to stop and seeing if you can maintain that remission, knowing that we're unlikely to lose a lot. If we did that, the patient would likely respond again if we needed to retreat them. Repotrectinib is also being studied in pediatric patients and has shown efficacy or activity both here in patients who are TKI naive as well as those who are TKI pretreated, with response rates of 60% in the naive patients and 25% in the pretreated patients. So again, if there's progression on therapy, that is very different. And those patients, I completely agree with Dr. Hong, they should get a biopsy to try to understand the molecular mechanism of resistance, and then consideration of repotrectinib if that is an on-target mutation in NTRK, and consideration of another therapy if it's an alternative mechanism. So this patient, you can see their whole course here. The patient was retreated with a targeted therapy, the same TKI as before, and again responded to that therapy, was treated for another year. The family wanted to try stopping again. We stopped, and again there was progression. So the patient was retreated briefly and then underwent surgery, and it has now maintained the remission for more than 3 years after surgical resection. There was some minor neurologic compromise to the hand afterwards, so we had a discussion with the patient or the family about whether or not they would proceed with surgery or not, but they really felt like that being the potentially curative option, they wanted to go with that and not continue treatment. So before we move on to the next section, I just wanted to introduce a video. This is one of my patients who actually has metastatic thyroid cancer, who was treated with an NTRK inhibitor, and she wanted to tell her story.
So gymnastics was really her primary activity outside of school. It's where she always wanted to be. She was spending hours and hours in the gym, and then we got this diagnosis that was very scary and, quite frankly, started with a surgery that took her out of the gym completely. The pediatrician called and said, "I'm so sorry I missed this. I've been a pediatrician for 22 years and I've never seen this in a child." Not only had the cancer progressed throughout and really grown a tumor on her thyroid, but it had progressed to much of her lymph nodes and was also pervasive in her lungs. Thyroid surgery requires a cut across your neck like this, and her first reaction was, what if they cut off my head by accident? So that was a really, and we were just completely unequipped to have that conversation. And, you know, of course, just being parents, we said that's not how, you know, we'll have the best surgeons and the best doctors, and we're going to make sure that that's not what happens. But it was really hard to explain that to her. So they were very positive with her that it was going to be a really long, hard road, but her ultimate prognosis was good, and that really helped her to have an anchor, to have something to say like, okay, it's going to be hard and it's going to take a long time, but I'm going to be okay. It was the genetic testing that took place post-surgery where we got a phone call from her doctor that said, actually, you know, interesting news, I guess you could call it, good news, bad news. One, it's a very rare NTRK marker on the tumor, but it means there are some drug options that are known to treat this, and we'd like Cora to be a part of a trial to use this. As we discussed what the options were, they really thought about, you know, if she was to have a traditional form of chemotherapy, that would have really completely pulled her out of gymnastics and even out of, you know, certain aspects of school, and would have been such an extreme lifestyle change for her. But this particular class of drugs, she was able to have a treatment that this was a child who was taking that drug every day and back in the gym and back with her friends, and actually was even able to compete in gymnastics while on this drug for 6 months. They were really tremendous about talking to her directly and explaining, hey, this is what's going on, this is what it means. They would show her the pictures on the screen and say, these are your lungs and these are the spots and this is what we're going to do about it. So she was very well informed and part of the process, which I actually think, again, gave her some governance over what was happening, but it also gave her the language to then go and sit with her therapist afterwards and talk about it, and also to talk to us.
If I were to tell someone who's going through this, I would tell them that they are brave and that they can do this, and that if you really put your mind to it and you really listen to your doctors and always stay positive, then you can probably get through this way easier than you think. And that, yes, it's scary, but it will always come to the bright side when you're done.
As a parent, that's very touching, and thank you so much, especially when you were talking about the 7-month-old and this girl. Well, glad we have the treatment options and the way they respond itself. Now we'll step up a notch. This will be a quick rapid fire where you'll be given 90 seconds to answer and explain the questions that we'll be asking. Diving into the first question, what are the clinical and pathological features that may help oncologists suspect and diagnose NTRK fusion-positive tumors?
That's a really good question. I think the vast majority of oncologists are probably not going to see secretory breast or masked tumors. Obviously, if you're able to identify those patients, you probably want to get that NGS and NTRK fusion on that. But the more common tumor types like lung and even thyroid, to some extent colorectal,
there's some kind of clues. One is that with lung cancer patients, what we've seen is NTRK fusions exist on what's called the molecular desert. They just have NTRK fusion. They don't, it's rare that they have lots and lots of other mutations that are kind of co-drivers or even maybe resistant mechanisms. And so if you find a patient that you're doing lung cancer and maybe you're in the community, you only have hotspot mutation analysis, you do EGFR, KRAS, et cetera, and you find no, ALK-ROS, whatever, you don't find anything, you're like, maybe, and especially it's a young patient, you may want to send that off for an NGS to figure out whether or not this patient has fusion. One other interesting aspect in colorectal, for some reason, there have been now multiple papers that show that there's a predominance of patients with MSI high that have also, that's kind of the opposite of what I just said, but MSI high that also have NTRK fusions. And so, at least on the trials that I ran, a lot of the patients, the colorectal cancer patients, or a good chunk of them, failed checkpoint inhibitor. They were sent to me and they had MSI high, but they also had NTRK fusion, and they respond beautifully to the NTRK fusion inhibitor. So if you see something like that, maybe a colorectal cancer patient with MSI high, and you try checkpoint, it's not responding. If you haven't gotten an NGS, you definitely want to try to get an NGS. Some of the other features that we mentioned, like in sarcoma, this spindle cell histology, some reason, seems to predominate towards NTRK fusion. So sarcomas tend to not have a whole lot of actionable mutations, but if you see that kind of spindle cell histology, and again, it's worth sending off an NGS.
Okay. Thanks. All right. Given the interest of time in 90 seconds, I'm going to be a little more strict on this, Dr. Hong. So I think that testing's getting better. We are testing more, but how do we make sense out of that dense NGS report in front of us? So how do you evaluate and treat NTRK amplification, overexpression, gene fusion?
Yeah. So to date, what we know is that all of this data is generated in NTRK fusion patients. When we did the initial phase 1 and phase 2, some phase 1 trials, we tried enrolling patients with NTRK mutations and NTRK amplification. NTRK amplification is actually almost as rare as NTRK fusions. NTRK mutations you will actually find in a fair number of patients, but none of these patients actually responded to direct TRK inhibition. So, I get that question occasionally, should I try larotrectinib or whatever on this patient with mutation? I usually say it's probably not going to work. We had on the phase 1 paper one patient who had amplification on their NGS, and we did try larotrectinib, and they did respond for a brief period of time, but it was a very brief period of time. Literally, after the secondary staging, they had progressed. So again, I would only really treat patients with NTRK fusions.
Thank you.
All right. Now moving to Jarushka there. Based on real-world evidence, how do outcomes of patients with NTRK fusion positive cancer treated with larotrectinib in clinical trials compare with patients treated with non-NTRK inhibitor therapies?
Yeah, so there is some data that informs some of these real-world outcomes in rare cancers. There's large data sets, the Victoria data set and others, that helps us to understand how these patients do. So far the real-world data suggests that these patients can do just as well as they have on clinical trials. In terms of non-TRK inhibitor therapies, very little data in terms of chemotherapy or chemoimmunotherapy. And certainly in lung cancer, for example, considering that after we have exhausted some of the TRK inhibitor therapies is a very reasonable approach. So we see here, this is an example of the real world data, and lung cancer is included in this data set alongside soft tissue sarcoma, colorectal cancer, salivary cancer, and thyroid cancer here. And the median overall survival was the primary endpoint. And we see here really that using propensity matching, those patients who were able to receive larotrectinib did appear to do very well here. And then we see here a couple of additional data points, and this is the Brose paper from JCO Precision Oncology, keeping within my time.
That's great. All right, this actually builds up to the question I had brought up previously. And you had touched on the NTRK activity with these TKI inhibitors. Can you reiterate, I see some thoracic medical oncologists in the audience as well, the activity when it comes to TKI inhibitors for NTRK fusion in solid tumors based on their CNS mets?
Yeah, so I think we walked through some of that data across solid tumors and in lung cancer. The intracranial activity, there's definitely intracranial activity that we see here, and it appears to be somewhat similar, maybe a little bit less, but somewhat similar to the activity in the rest of the body, response rates of about between 60 to 70%. So I think here in terms of how we approach this in clinical practice, usually if patients have a small number of asymptomatic brain mets, we can feel comfortable to give the targeted therapy on its own. In those patients who might have a larger metastasis, single metastasis that requires, from which they're acutely symptomatic, we may prefer surgery. In those patients with between 1 to 5 brain metastases, which are suitable for stereotactic radiosurgery, or 5 centimeters or less, which is the usual cutoff for stereotactic radiosurgery, and who are symptomatic from it, we will usually start with that and then subsequently treat with the targeted therapy. So I think some nuance there. Again, there's institutional differences, but broadly, that would be our approach.
Dr. Latch, while we're on the topic of CNS mets, we'd love to hear for a pediatric population.
Yeah, so as I mentioned, gliomas are actually one of the most common pediatric cancers and one of those that more commonly have NTRK fusions versus other common pediatric blastemal type tumors. And there is some data on both larotrectinib and entrectinib in patients with CNS disease. So this is data from larotrectinib in patients with NTRK fusion positive primary CNS tumors who were eligible for the SCOUT trial. And you can see the overall response rate is 37% with 74% 24-week disease control. Notably that this was a phase 1 trial that did not require measurable disease in all patients. So if you only look at those with measurable disease, the objective response rate is actually higher. It's 52%. And again, these tend to be very young patients with CNS tumors where we're often much more reticent to use radiation, for example, due to the effects on the developing brain. And here you can see duration of response, progression-free survival, and overall survival. Again, quite good for patients with primary brain tumors. And similarly, here's the entrectinib data that I showed earlier, but again, the patients with stars are those patients who had primary CNS tumors. So again, you see a very robust level of activity of both larotrectinib and entrectinib in those with primary CNS tumors. And again, something I definitely would consider for those patients.
All right, one last question before we close this rapid fire round, and this is something similar to what we saw the case for. What is the efficacy of TRK inhibitor therapy in pediatric patients with thyroid tumors?
So again, NTRK fusions are very common, especially in the very young patients with thyroid cancer. This is a study looking at the incidence of fusions by age, and in those patients less than 10 years of age at diagnosis, 93% of them had a fusion, not all NTRK, but a kinase fusion at diagnosis, and then that incidence decreases with age. So in very young patients with thyroid cancer, very important to test to identify these. And we also know that in patients with fusions, they are less responsive to standard therapy, meaning radioiodine therapy, than the patients who do not have fusions. So here's data for patients with thyroid cancer in general. There's not that much pediatric-specific data, but again, a high level of activity, response rate over 80% in those with papillary thyroid cancer with an NTRK inhibitor. And what's really exciting, in which we actually have several clinical trials ongoing now, is that in some cases we see these drugs cause increased radioiodine uptake. So the scan on the right is a published scan where a patient had radioiodine refractory or radioiodine non-avid cancer that became quite avid. You can see the uptake in the lungs with treatment with larotrectinib. So we have trials now combining these agents to see if we can further improve these outcomes.
Perfect. Well, thank you for walking us through that. Now let's get a little candid. Let's go off script. Let's talk about some real challenges that we see in the community in our day-to-day clinical practice. I'll start off with you, David. In terms of overcoming challenges, what are some of the challenges you see? Either the testing technology, could it be the RNA versus DNA that we're talking about here? Inadequate tissue? Is liquid tissue good enough? Do we have to rely on solid tissue? clinical awareness, hoping that sessions like this will continue to bridge that gap. The turnaround time, I think, is getting better, and I think financial toxicity is something we should always keep in mind. Dr. Hong, on your end, what are some of the challenges you see out in the community or the second, third opinions that you get when it comes to NTRK testing?
I think the biggest one was just awareness, right? Awareness that these drugs could have such incredible benefit. I think now that NGS is reimbursable, I think more people are able to do it. Back when I started actually this trial, we were limited by reimbursement, by limited access to technology, et cetera. But now that is more aware, I think it's, in my opinion, I think it's probably more clinical awareness.
And I'd have to add, I think that exactly things have improved where high cost is certainly not an issue because a lot of it gets reimbursed. Long turnaround time, as you said, has improved. Clinician awareness, with regards to that, I know that these are dense NGS reports.
Yeah.
Now, though one could see NTRK fusion where these drugs are approved, but if NTRK mutation is present, those are or overexpression that we talk about. In those circumstances, one is tempted to resort to these therapies. So those are some nuances that we just need to continue to bridge this gap and continue to reiterate that those still exist.
I'm actually really surprised by this limited access to testing technology. I don't know if it's, if it's hospital-based or if it's, practice-based, because, there's 1,000 vendors now out there, right? So I'm really kind of surprised.
I also think it's a global audience that's virtual. So I do think that we should acknowledge some of those differences. And I think this would be a good bridge to hear from Dr. Naidu as well. What are some of the challenges internationally?
Yeah, no, I think this might touch on the fact that obviously this has evolved, but at an ASCO presentation here not too long ago, 3 or 4 years ago, even in the US, the access to next generation sequencing in lung cancer was 50%. And now in an updated JCO Precision Oncology paper a couple of weeks ago, published by Sandeep Patel and colleagues, that's now come up to 70-75%. So I think that it is better, but certainly in lung cancer, tissue is the issue. So inadequate tissue or perhaps a confusion about the different methodology that should be used. DNA versus RNA, how do you interpret this? How do you time it? If you have somebody that is acutely unwell where you want to do IHC or FISH first, what do you prioritize? What do you do next? I think that might be what that is touching on. And certainly I would say in the lung cancer field, there is still constant debate about this. And now what we've seen is, say in lung cancer, the neoadjuvant setting, now we're starting to do this testing even in early stage cancer. How do you rationalize the order of your testing and what is a one-stop shop way of doing it? And then adding on ctDNA and others, can we test for rare alterations? What's the implication for fusions? What platform allows us to assess fusions with equal sensitivity as DNA? I think that's what that means, and it is complicated for some tumor types. So we're very fortunate. I think I'm in a small country where this is possible to centralize. So we have 2 national next generation sequencing laboratories that do all the NGS for the entire country.
Wow.
So this allows us to standardize our approach and make sure there's equity and access. But there's variation.
Yes.
And certainly within the US, there's a great deal of variation, and that is definitely true of a global audience.
Ted, we'd like to hear your thoughts from pediatric standpoint on the same issue, but also when you have multiple NTRK inhibitors available, how are you picking? I know side effect profile is one aspect, but besides that, because they're all so well tolerated, how are you picking one over the other?
Yeah, so it's a great question. So in pediatrics, we're somewhat fortunate in the United States, actually, that the NCI has funded through the Children's Oncology Group what's called the Molecular Characterization Initiative, which is free next-generation sequencing for any child with a brain tumor, rare tumor, or sarcoma that uses RNA-based NGS as well as DNA-based testing and methylation profiling for brain tumors. But we have been very fortunate that has tried to eliminate many of these barriers. So we struggle with the same things, that there is still lack of awareness and people don't understand. We also struggle with some lack of data, that people will have different opinions about which agents should be used in first line, especially in things that are not widely metastatic. So those are some of the challenges that we face, but in the US, that has been something that's really overcome some of those barriers for our patients. It still remains a struggle internationally, of course. In terms of picking agents, I don't have a perfect methodology. I will say that there is the most data for larotrectinib in pediatric patients, just in terms of numbers treated, and that was the first agent to really have a pediatric formulation, which I think is what led to that increase in data. So that is often the agent that we use. First line is the agent that was studied in the COG trial, but all of the agents, have some and growing pediatric data. There's an ongoing pediatric trial of repotrectinib, and so it is a discussion with the patients and the families about what the available formulations are, what the side effect profile is, and then which agent they choose.
I'm glad you're the pediatric hematologist, oncologist here, because again, formulation is usually not the first thing on our radar, or keeping someone who's starting at 6 months up until 80 years and having that conversation at 1 year. So thank you for that. When we were talking about this, so side effects, Dr. Hong, you touched on this. Dizziness is one thing. Is this dose dependent? How are you managing that? Any clinical pearls around that?
There are certain people who seem to be at a higher risk. I think, we talked about pediatric patients rarely have this dizziness, and maybe part of it they can't communicate, but it seems to me the older the patient seems to have a higher propensity of dizziness, kind of proprioception, difficulties, etc. The best thing we tried everything prior to this. We tried, scopolamine. We tried, your traditional things that you would think of. But the best thing to do is to hold the therapy and then to just dose reduce. And these patients had responses even, it's right now, I think Laro is at 100 BID, but would, even at, lower doses, half of that, we were still seeing responses. So the best thing to do is to hold, if it's intolerable, to hold and to dose reduce. Now, most of these side effects, in my experience, do get better over time. It's almost as if the body and the patient begins to become somewhat tolerant to those things. Yeah.
Dr. Naidu, while you're managing this particular patient, what you presented in during your discussion was a PD-L1 high score patient. Now, if there is no PD-L1 available, or PD-L1 negative for that matter, now the disease has progressed, was on second generation TKI. What is your next step after that? Are you using chemotherapy or chemoimmunotherapy in a PD-L1 negative case?
Yeah, so I think in the PD-L1 negative population, it's a little bit trickier to understand what the IO adds, particularly in the second line setting and beyond. I think there's a couple of factors that will go into that treatment decision in lung cancer. So we now know from the Ipsos data, this is the phase 3 data that was published in Lancet Oncology, that even regardless of PD-L1 in the older population, the slightly frail population, sometimes there can be a benefit from a little bit of the immunotherapy. So you're talking third line now. Right. If you've already had larotrectinib or entrectinib followed by repotrectinib. So third line, I think we're a little bit, giving platinum doublet chemotherapy there in a fitter, younger patient is probably going to be the standard thing to do. I think in an older patient or maybe a frailer patient, then you might have to modify that to some degree. The question of adding the immunotherapy, particularly as a third line option in the PD-L1 negatives, I think, there's going to be people who see both sides of the coin there. I would say in my clinical practice, I'd go with the platinum doublet chemotherapy, and I probably would hold on the immunotherapy, particularly when we think that targeted therapies, these patients who respond this way are unlikely in general to respond to immunotherapy. If the case is PD-L1 high, this becomes a little bit more debatable, I think. But in that case, that's usually what I would go for.
I'll open this question to any of you. With regards to NTRK inhibitors, they have such good responsiveness over other genetic alterations. What's the science behind it? Why is that the case that they tend to perform so much better when compared to the others?
I think there's, if you think about like what was the poster child of all targeted therapy is imatinib, right? And BCR-ABL is a fusion, right? There's something about fusion biology that really drives that tumor is oncogenically addicted, right? Whether it's ALK, whether it's BCR-ABL, whether it's NTRK, et cetera. There's something about fusion biology that truly drives a tumor. And like I said, at least with NTRK, I can't say more per se about some of the other fusions, is usually in the context of a desert landscape. There's rare, for example, the other area I work in is RAS, right? We now know with G12C inhibition that there are certain co-alterations that kind of blunt the effect of RAS inhibitors, like KEAP1, et cetera. So you rarely see that in NTRK or fusions in general.
Another topic when we're dealing with this ends up being multi-D. Multi-D is always the right answer. Oncology is cancer sport. But again, relying on that radiation oncology colleague like Dr. Naidu did in that case, if you have that oligometastatic disease while they're on NTRK inhibitor, could you radiate that oligometastatic disease and then continue on with these NTRK inhibitors? Is that what you would do in your clinical practice?
Definitely what I would do.
Yes. Yeah. Similar story for pediatric population as well.
Do you see anything co-mutation where, in those cases, would you target that co-mutation, or NTRK is so responsive, just stick to that and consider them maybe in second or third line?
Just in general, pediatric cancers, of course, have fewer mutations than adult cancers. And so it definitely is almost always the only driver mutation. We do sometimes see co-occurring loss of CDK in 2A or B as a secondary alteration, and those patients still respond to the TRK inhibitor, so I have not tried to target that separately.
These mutations are rare. All three of you are working in academic settings. Are there resources out there for us in community settings to rely on to go over that molecular report, or these generic tumor boards that one could participate and have someone from institutions saying, okay, this is what I would do, or this is what this report really means?
Yeah, you can email me. If you find an NTRK fusion patient, email me. I'll happy to walk you through it.
But are there like any active tumor boards that are open to other institutions?
Yeah, so I mean, I can add there, and I'm sure it's the same at MD Anderson. In the US, Hopkins has a molecular tumor board. It's run by a breast oncologist and a molecular specialist, and they accept external cases. And that's usually once a month, and you get a very comprehensive report from it, detailing exactly, the interpretation of the NGS and what the recommendations might be. And usually a physician has the opportunity to even present their case in the Republic of Ireland, and I know in some places in Europe. So we have a national molecular tumor board linked to our Cancer Clinical Trials Network through Cancer Trials Ireland. So a practitioner can submit a case, and then it will be discussed by a medical oncologist, a molecular pathologist, and a national pathologist, and they will get a comprehensive report from that. So, and I think these types of interfaces are developing, across the world. So certainly there are resources that can be used, and I think they should be used. And this is exactly, what they should be for, is rare molecular alterations for which the data, might be, only those who know it well or those who use it a lot, and that's not going to be in the community.
Another question, given how well they respond and overall safety profile is so good, if seen in early stage setting, outside a clinical trial, any role, because since we are testing more of this NGS because of EGFR, ALK mutation, any role outside of clinical trials in early stage?
You mean
neoadjuvant?
In that
adjuvant setting or chemoradiation?
Or like stage 1 or stage 2? I'll be honest with you. I think that, obviously, patients with stage 1 or 2 probably have curable disease from standard of care. I probably would stick with that first. And so right now, I wouldn't say, if you have a curable case with standard of care, try that first, right?
Thanks.
I would just say in pediatrics, I think about that a little bit differently. Like the patients I showed with infantile fibrosarcoma, that patient had curable disease. If you amputated his arm, he would be cured. We have seen a lot of success using these to reduce tumors and allow curative surgery. And so we've used chemotherapy for that in the past, and at least in my practice, have moved to use these TRK inhibitors because we do see more rapid tumor regression than we've seen with chemotherapy. So it's a little bit different.
Thanks.
Can I come back to the whole idea that tissue is the issue here? And David, you brought this up a few times, that at the time of progression, consider biopsy. Could you just rely on liquid NGS? Given the tumor heterogeneity, you might be able to pick that resistance better. Are you doing both? Are you doing liquid and solid? Or tissue is the only way to look for this?
Yeah, so one of the problems with cfDNA is with cfDNA, you kind of have to know what the partners is. If you have a rare NTRK partner, you're not going to pick that up per se in the cfDNA. So, and part of the reason that RNA-based therapies with cfDNA is not really possible because you need to know the partners in order to create that cfDNA analysis. So I think that really the tissue is the best gold standard to identify.
Would it be any different for a pediatric population?
No, I think about it a little bit differently in that the identification of NTRK gene fusions in cfDNA, I agree, is very difficult and not something I would recommend as a testing methodology. At the time of progression, when you're looking for an on-target resistance mutation, cfDNA is actually pretty good for that if your tumor secretes cfDNA. So I think for screening for these, tissue is the issue. For at the time of progression, I still recommend biopsy because not all tumors secrete cfDNA at the same way. Not all lung cancer, but if a biopsy is difficult, cfDNA can be very useful in that sense.
Thanks. Well, thank you so much for walking us through the NTRK space. Thank you so much, Dr. Lash. Thank you, Dr. Naidu. And thank you, Dr. Hong. And thank you all for joining us. Thanks so much.